If not, you have
Hi,
to
Dr.
come in.
Luke.
Hey,
How are
how are
you?
you?
I'm doing well.
What a day. What a week.
Trying
Wow. You have lots of
to-
people are interested in PRP.
yes, they are. So I was trying to get Dr. Hade, but I can't find.
Wait, but we supposed to join you. He's coming on, right? It's three
Yes.
people.
Yep,
And I hope Instagram allowed that. I don't know.
they
I've
do.
seen three.
I was
Okay.
trying to invite him on his Dr. Hade account, unless he's
He's
joining.
coming. Don't worry. My marketing person's running to his room to
So,
get a hold of him, so we can
so
have him talking a little bit more.
patients,
I'm sorry.
busy day treating patients.
Yes, it's been a busy day as always. It's not easy. We have happy patients. We have patients who are still struggling. We have be with them throughout the way, the journey. You know
Yeah.
how it is. It can be difficult, but then and I see patients. You know, luckily, majority of our patients do ultimately get pregnant and everything, but sometimes it's very sad. I see patients who struggle, went to other centers and felt like they're repeating the same regimen and they want some alternative thinking, and so not easy.
Well, I always hear good things about your practice in our community. So
We try, we try, we try.
I
Where do you
just
live? Well, I'm sorry, I should not ask that, right? For today, in the east
oh
or
that's
west? Sorry.
I won't give specifics, but I live in Long Island, New
Oh,
York.
you're in New York. Okay, so you
Yeah.
do here. Sorry, I'm like, well, if you're in
Yeah.
West Coast, how would you know?
I actually started my frozen embryo transfer cycle today.
Wow, very exciting. And are you close to it, or you started? So you
I
just
it was cycle day 3, so I went in for my first
I
monitor.
see, I see, I see. Oh, some of your audience is talking about their own experience. Not to worry, praying. We'll be praying. And never know. One of my lowest beta was 7. My
Really?
patient, yeah. Actually, it was 9. Sorry, 9. Actually,
And
no, 7 was long time ago. 9 was the 3. I think the child was like 4 years old, 3 years old. Not
oh,
easy, not easy story. Some of the stories are very hard. This was a hard story, and I think it's a miracle from nature, and I'm just assisting. She lost her child actually at 8 or 9 years old,
no.
and so we try and try, but we try to get the little girl embryo, but we can't. We got a point embryo, and that's all I had after 20 IVF cycles. Is he coming on? He requested to join.
Okay, I just accepted it.
Okay, Dr. Hay. And so we finally got her pregnant. So anyway,
Hi guys.
hi, Dr.
Sorry
Hay.
to be late, but better late than never, right?
Not
Yeah.
a problem, Dr. Hay. Thank you for joining
Well,
Fertility
thank you.
Tribe. Sorry, I never really introduced you to Dr. Hay and Dr. to you. So please, guys, if you guys want to do a little introduction here.
I'm Kristen. It's very nice to finally meet you.
Meet you, Kristen. I'm and pleasure to meet you.
Awesome. Well, I am really excited to talk about this topic because I've never even heard of it until until Dr. Luke brought it to my attention. So, PRP, tell us, what does it even stand for, and why would you use it in an IVF protocol?
So PRP is just a simple way of saying platelet-rich plasma. So it's actually an old technique that's been around for about 20 years, but just the application is new to the IVF and fertility world. So it's been used for plastic surgery, in orthopedics, in dermatology for a long period of time. But really what they're finding now with, especially with patients who need skin grafts, that really accelerate the growth of skin cells, fibroblasts, using PRP. And it probably does so by having in the platelets themselves, they have about 30 different growth factors and proteins and cytokines, which are messenger type of molecules that help direct the healing process in tissue. So I always think of the platelets kind of like the cops on the street. So like when surgery to an area, it walls off the area and says, okay, peel off, make sure that crime doesn't escape from this area, and then it starts to go to the work to instructing, you're going to go here, fix that, you're going to repair this, and it's giving all the tools that are necessary. So when you take the plasma, depending on what you're going to introduce it to, what you're trying to do is basically increase the vascularity and growth of new blood supply to improve the likelihood of expedited growth. So I know that we were going to talk about uterine PRP or endometrial PRP. So we're looking at for women who have very thin endometrium, that's usually some type of either prior scarring or damage, something that's either finite or very fine scar mesh that you can't see with a hysteroscope, or very even thick, dense bands, where you want to then dissect all this tissue and actually start to try and create damage with either scissors or curettes, which are metal instruments scraping. Think of it like tilling the soil. And then what you want to do is put a new layer of topsoil on. So you want to get that growth nutrients back in, so that you can get, once you're exposing the lining to estrogen, you're trying to get it to regrow. And we have successfully completed this in one patient, and the N of one isn't always powerful, but it's significant because this woman had, and Dr. Luke would know better, how many years of treatments with no success, and a lining of 2 millimeters where the average should be a minimum of 7 or more, and ideally 10, and we got her close to 7 with this therapy.
Wow.
Yeah, no, it's a great story. It's a patient with a fibroid, and when you go through a large surgery or fibroid surgery, her lining becomes very thin. We don't know why, and so it is a very difficult situation, because now you got the embryos, and it turns out it was never her embryos problem, because now it's so easy to get normal embryo. It was never her uterus problem. We never know what problem, because she's 38, but it shouldn't be an issue. But then it turns out maybe it was the fibroid issue, that she had time intercourse and never got pregnant. Then after you remove the fibroid, her lining was so thin for whatever the reason is. And so she was one of our first patients doing PRP. We have a couple patients coming along, and we will hopefully publish our data at the end of next year. But with a very thin lining and using PRP to rejuvenate. And the plasma is very interesting. This is actually a patient's blood. And I was not a huge fan. So some of my patients even yell at me. One of my patients with just reasons like, Luke, you said don't do it. And that was last year when majority of our patients did ask me, well, some of the patients who were interested in doing it, and majority of them went elsewhere and did it. And so I kept on saying no, because I didn't see any effect. They came back, right, to cycle. And I'm like, hey, you didn't get any more eggs than before you did the PRP. Then I did another patient, another one, and eventually there was someone that responded. We had about 2 to 3 patients, never had a period or a cycle. It just has been very difficult for them. And after PRP was done, they were able to do that, to have follicles. Now this is the hard data. You guys are not asking me to have follicles. Oh, not me, Dr. Hade. Many patients coming to us is asking for a baby. Not can you retrieve my egg or get one egg? So it is a very, very difficult decision in some ways, because financially there's a lot of, is the cost of it. Dr. Hade, how much is it, the cost of one treatment? I think we're trying to make it economical, basically.
Yeah, it's about $4,000 for a single application of ovarian PRP injections. Because it's a surgical procedure, it's similar to an egg retrieval, so there's a lot of preparation and OR time that is required to inject the PRP into the ovaries. There's also about a minimum of 3 to 9 day prep time that the patient has to do. And I hear that there are some patients who go to other centers and do it and prep for restricting the intake and ingestion of things that may inactivate platelets, like blood thinners, aspirin, fish oil, hydrated fish oil. So these are things that you want to stop for about minimum of 3, but ideally not more, pre and post the PRP therapy, because you want to make sure you're giving therapy the best chance to improve outcome. You say, okay, well, who is a candidate? I have a lot of people asking. So let's start with what the autologous plasma does and does not do. It does not increase or improve the quality of the eggs that we get from an individual. So someone 45, 46, 47, this is not a therapy to make better eggs. The concept is to try to get more, increase the quantity, because there is no current therapy for that. So this is an experimental attempt to see if we can boost through this process of getting the ovary to be remodeled and revitalized in a way that we can either hopefully get some of these primordial follicles to snap into antral follicles. And the antral follicles are the things that you always see us feverishly measuring, looking for on the ultrasound when you come in to start a cycle, because those are the only follicles that can respond to medications to release an egg. The whole goal is if you have an antral follicle, I can give you a medication to try and drive the follicle to ovulation. But we're finding that conversion from primordial follicle to antral follicle is about a 90-day window. So you actually may not see any improvement in 90 days. But we are seeing some women getting a marked improvement in the number of antral follicles much sooner than that. And I think what it's doing, those antral follicles that are assigned, so the natural course is your primordial follicle. And I tell everyone, I think more like the New York City Marathon. You get an invitation to run in the New York City Marathon. Get that invitation 90 days before the race actually happens. So when you get that invitation, you are either going to be invited to run, or you're not going to get an invitation to run. If you don't get an invitation, that primordial follicle will either undergo program apoptosis is the method that we use, or
Dr. Hade,
yeah, this connection, Dr. Hade, the connection.
oh
Can we find out? Can go over his room so we can like change his location? What about me? Is it better where I am?
yeah, his is
Okay, so I may have Dr. Hade comes in to my room to talk about PRP, because I think we are losing followers. People cannot hear us. But the reason I want you to introduce you to Dr. Hade is because Dr. has been doing really heading out on this PRP. We are doing some major clinical studies on this research. We are, and I saw some of your beautiful audience having questions. Do you recommend PRP after a failed transfer? I'm going to leave this to Dr. Hade. But I'm very excited to, introduce you, Dr. Hade, about PRP. Can you hold one moment? I'm going to have him come here so then he can maybe better.
See me now? I'm in Dr. Nate's. Can you see me now?
No,
Is this
I can
better?
see you. I think your audio is much better.
Okay, so Dr. Nate Johnson right now. So,
Oh, wait. I don't
Yeah. Just end it?
Yes, I'm on. Okay. Oh, my phone is on, right? Yes. Oh, great. We're still here. That's great. Let's not lose anyone. Dr. Hade.
Here I go. I get into the hot seat. Here.
Okay.
I feel like I'm taking my boards all over again.
We should take a little picture. It's so cute. Like this. Anyway, okay.
So I have no idea where I left off that you heard or didn't hear. Was it at hello?
I think we heard a lot of it going in and out. My question is, so you were talking about ovarian PRP. Is that different from the uterine PRP?
Right. So endometrial PRP is only for women who have chronically thin endometrium and likely of high failed transfer rates. So that's for, and that only represents about 1 to 2% of all women with infertility issues. So it's the minority. What the ovarian PRP is to help drive a higher antral follicle count. And we think that's done by two modalities, either by helping those antral follicles that are competing in that month and preventing them or reducing them from undergoing programmed cell death, and by getting more primordial follicles to eventually become antral follicles 90 days later. So it's we think maybe a twofold. It's unclear really how the benefit is happening. And not all women get the benefit, and that's why it's still experimental, because we're trying to understand, is this actually a viable therapy for women?
Okay. So, so it's 1% can help people.
For endometrial. No, so with endometrial PRP, the pregnancy rates, the improvement is about 70 to 80%.
Wow.
It's dramatic. With ovarian PRP, the literature suggests somewhere between 20 and 70%. I think it's probably going to be closer to like 40 to 50% when it's all said and done. But we will need to collect more data and see what the true benefit in our hands is.
Okay. So you said it was 4,000 per treatment. How many would that just be one treatment typically?
Right. So we do packages of 3 treatments for $10,000. So we give a discount for people, because it's, if you look at the data, women who do monthly treatments for up to 3 treatments will have the best prognosis and outcome.
Wow. Okay. I think a lot of people their minds are blown because they've never heard of this before, including myself. And like, why do my doctor recommend that? Because you guys are really studying and trying to see what the benefits are on it.
Right. So when you look at, there's probably only a few dozen centers in the whole world that are actually providing PRP as for ovarian and endometrial injections. And to be honest with you, when they're creating PRP, not all PRP is the same, because you have to basically separate the red blood cells, the white blood cells out from the plasma, and then you have to then concentrate and remove the platelet poor section of the plasma, so you're left with only the high concentration of the platelets. So you're increasing the concentration of platelets by about 500 to 700% that you would normally have in, let's say, 1 milliliter of blood that's traveling. So this is really giving a maximum impact. So depending on how people are preparing it, we use a company and a technique that is FDA approved. Some people in some programs, when they create PRP, they may be just spinning these tubes in standard blood tubes that we use to separate plasma, commonly just to run the assays and the blood work that we do. And that is not concentrating it, and that's not getting a adequate separation. So if you leave white blood cells behind, you can increase scar tissue, because that creates the inflammation. Those are the cells that fight inflammation and creates inflammation and scar tissue. So, those are the immune cells of the body. So that's what we really want to remove everything and just leave the cops on the beat behind, so that we can negotiate and increase the vitality of the tissue.
Okay. I think someone asked in the comments, but is this something that could help with endometriosis?
I'm sorry, can you say that one more time?
Oh, am I breaking up?
Yeah.
Is this something that could help with endometriosis?
So I don't know, and it's not been applied to endometriosis. So endometriosis is an autoimmune issue. So there are some exclusions of people who are not eligible for PRP. So you have to have normal blood counts, and obviously you have to have normal platelet counts. So you can't have any type of platelet disease and usually uncontrolled autoimmune disease like diabetes and thyroid disease, because that will actually make poorer outcomes. So you're just trying to find who are the individuals that are optimized. With endometriosis, it's an unknown, you're having tissue of the endometrium that's making its own implants. So this actually won't cure that problem. Endometriosis has other issues, but for the most part, if you can get viable eggs with endometriosis, there are other medications we can give to try and improve the implantation of the embryos that we get.
Okay, got it. So can you give us like an example or two of patients that you recommended so that people can know if they're a candidate?
I'm sorry. It must be all the internet in our facility right now with the storm. Can you say it one more time?
Yeah, no, I was asking, can you give us an example of the type of patient that you're recommending this, over the past couple of months? Any come to mind?
So it's women with, we're offering it to all women of any age with severe diminished ovarian reserve. It's for women who only have somewhere between either are menopausal or perimenopausal, regardless of age, and or who have done IVF treatments or are thinking of doing IVF treatments and only have 1 or 2 antral follicles on ultrasound. So these are the individuals who I think could benefit most. And when you look at the original data, it was done in women who were menopausal, who were under the age of 40. So that is really the targeted group that may benefit because these are women who, because they're young, could potentially have high quality eggs, and I don't need many eggs then to get the live birth versus someone who's coming in at 46, 47 and trying these treatments. Even if I go from 2 to 6 eggs, the amount of eggs you still will need to potentially create a live birth, it still may not get you enough to the level and degree that you need to get that live birth. But it will increase pregnancy rates, but it may not increase live birth rates in those individuals.
Okay, gotcha. So prior to, can you hear me okay?
Yeah, I can hear you.
Prior to a possibly egg donor, this might be something that you would try.
Right. So if someone is reluctant and they're saying, I want to have one last shot at a treatment, then I would say, okay, as long as you understand that it's experimental, there's no guarantee that this is going to be of any benefit to you at all, then I think that I owe it to them to at least try the most that we can offer at this stage in the game to see if we can maximize the pregnancy rates. That's for ovarian. Endometrial is totally different. Endometrial PRP is really for those women with thin lining who are multiple failed pregnancy rates. These may be treatments that may improve implantation, but it remains to be seen. It's interesting, and we've been having excellent success so far.
That's awesome. So I mean, yeah, if you're having implantation with, say, PGT normal embryos, this might be something you could benefit from, right?
Exactly.
Awesome. Well, this has been really interesting. Is there anything, I don't even know what questions to ask because this is so new, but is there anything else that you think, if someone has ovarian reserve, that they should know about PRP?
Right. So I also tell everyone, it's a surgical procedure. We do it under anesthesia, unlike an egg retrieval where you can do without anesthesia, because I'm not decompressing the ovary. I'm actually injecting the PRP and making the tissue edematous. I'm swelling it up, so it's uncomfortable. It holds the same risk that an egg retrieval would hold, which is really, even though it's about a 1 in 20,000 to 1 in 50,000 risk of blood loss and infection, and a pelvic infection following, which can be a life-threatening issue. It's super rare, but not impossible. And I tell people that you have to understand that it's surgery. There's always risk involved with every surgery, and you have to weigh the risk and the benefits and say, will you get the benefit that you want, which is really what we all want for our patients, which is to make a baby, right? Will you get that outcome? And that remains to be seen at this point. But we're trying our best to get them with new techniques, because right now there is no other option. That's the problem. I have zero options to improve the amount of follicles that I could stimulate for many women, and at least now there's something that we can try. It's not ideal, but it's something, and something's better than nothing, in my opinion.
Agreed. So someone's asking, how long do the results last for ovarian therapy?
So it's unknown. It dissipates relatively quickly, but again, if you're looking at it with increasing your primordial follicles to the antral follicles, you'll probably only get the benefit from that in that 4th month, 90 days after the injection. But you may see it with the following month, with the increase in survivability of the antral follicles that are competing for ovulation. So it's a dual edge, and that's why with 3 months of therapy, you should see improvement in outcome month 4, 5, and 6. What we also offer here, which many programs, I don't think anyone else is, that we'll do it at the time of egg retrieval. So if, let's say, someone's doing an egg retrieval, this way I could do both procedures at one surgery, where we'll go and we'll extract the eggs first, and following the egg extraction, we then inject the PRP and then have the patient come back 2 weeks later and see what the antral follicle count. And that's what we've been pleasantly surprised in some of these women.
Oh, wow. So then they would do sort of a back-to-back cycle?
Exactly.
Okay. Which a lot of them might be anyway if they have ovarian reserve.
Right. So when you're dealing with someone who maybe have, over the age of 42, and time is really of the essence, and they don't want to lose any time, I don't want them to wait 90 to 120 days before you see an outcome. I want to keep moving forward and try and improve every single cycle between there.
Right. That's really a really cool option, I think, because not everyone. Some people really want to try everything before they move on to a donor.
Right, and I look at it that it's actually a little bit easier to get a wider distribution of the PRP into the ovarian cortex, and instead of in a small ovary, it's a little bit more difficult technically, because you're trying to get something into a more solid organ, and as opposed to something where there was a follicle, it's softened the whole ovary, so it's easier to get the spread of the PRP throughout the entire ovary. So it's something novel to what we're doing here at Generation Next.
Very cool. Well, is there anything else? I think we covered a lot of it, but you're the expert.
Well, let's hear what other questions people may have. I don't want to hog up all the time.
So we asked about, you mentioned over 40. Let's see. Actually, this is a good one. Would PRP help at all for recurrent miscarriage?
Unlikely, because it all depends on what's the cause of it. There's so many causes of miscarriages. The most common are usually just chromosomal abnormalities within the pregnancy itself, unfortunately. So it will not change quality. So if you're asking if the miscarriage is caused by a chromosomal anomaly within the conceptus, will it make better eggs? No, it will not make better eggs.
Okay. Someone, I guess, has a follow-up question about why it wouldn't work on a diabetic.
I'm sorry, say that one more time.
Why would PRP not work on a diabetic patient?
Because when you start to change the hormonal milieu, and so insulin creates, and it's an inflammatory process, so you're just weakening the effect of their platelets and the growth factors that are required. So insulin augments a lot of different hormones to do with their functioning normally, to make them function abnormally at their receptor site. So if someone has hyperglycemia, diabetes, and especially if it's not controlled well, these techniques, number one, you don't want to take a diabetic back and do surgery because you're increasing their risk of an infection. And remember, these are vaginal treatments, and because you're going through the vagina. That's just higher rate of some type of infection. So you want to optimize the therapy.
Got it. What about PCOS? That can be a cousin to diabetes?
Yeah, as long as they're not actively diabetic, it shouldn't be an issue. But again, this is not for PCOS, because PCOS have the opposite problem. They have a very high reserve, and they have a high egg density, but they just tend to make poor quality eggs per egg retrieved. But believe it or not, our PCOS patients usually have the highest success rates because they're getting the most numbers of eggs per treatment, and as a result, with the higher eggs, gives you a better chance of a baby.
Okay. And would you recommend for lipid?
So make sure I understand this. If I didn't catch that, you were breaking up again.
Would intralipids be beneficial in conjunction with PRP?
So intralipids, it's an interesting concept, because what you're saying is you're injecting fats into the circulation, and these fats are inhibiting your immune functioning from working. It hasn't been studied, so I can't even speculate yes or no if that's going to be of any benefit to the patient. I think it all depends on it. So it's not going to increase the antral follicle yield. So let's start this way. I don't think it's going to improve that outcome. Could it do other things to improve outcomes? Well, I think it all depends on if you're dealing with someone with autoimmune issues, can that intralipid really tamponade the immune system from being hyperactive? I don't think in the era of COVID that would be medically responsible to start giving people a lot of autoimmune suppressive therapy, because then that gives you a higher problem of contracting of one of these viruses that could be problematic and detrimental to not only your health, but especially if you become pregnant. COVID in pregnancy is detrimental and increases the miscarriage rate.
Yeah, absolutely. Someone else asked me about immune disorders be helping improving success rates.
Yeah, so if you look at the guidelines from the manufacturer for who created the FDA approved, and there's a lot of different modalities and methodologies that you can use to create PRP. So that's why you have to look at wherever someone goes, what is their method of creating the PRP, and is it something that's actually concentrating the platelets, yes or no, and the growth factors, and really separating out those white blood cells and red blood cells. So autoimmune disorders just typically alters the way that the whole dynamic of the white blood cells and the platelets are functioning, because like I said, if you have an immune reaction that's creating platelet dysfunction, then what's happening is you're just lessening the efficacy of the treatment.
Well, this is super interesting. I think a lot of people are going to be asking their clinics if PRP and/or coming to next. Well, thank you, Dr. Hade. Is there anything else you wanted to add?
No, I want to thank you so much. It was a pleasure meeting you today. Hopefully we can meet in person at some point in time.
Yeah, absolutely. I'm only right away, so for sure.
Great. Thank you so much, and have a wonderful day.
Have a great day.
Bye-bye.